we are very fortunate to have so many neurologists today. And my first question is, there are many anti-seizure medication, and what I've seen is many of you use valproic acid as, I would say, I don't know if it is first line. What is your thinking in the use of seizure medication in creatine transporter deficiency? How do you start? You know, obviously, you look if they are generalized, if they are focal, and all of these things. But, you know, in general, at the end of the day, what do you give first, and how you follow up with a second seizure medication?
May I? Okay. You will complete.
I can conclude.
Okay, perfect. 1, 2, 3. Okay. So thank you for this question. So the question of treatment is a good question. What we noticed interviewing a lot of families now is that sometimes the diagnosis of generalized epilepsy was made without, I mean, it could be a little bit corrected or reanalyzed in a different way. So in several patients, we were able to be sure that they had a focal onset, definitively, whereas it was not always noticed first. So I think that the first thing is just to be able to interview the families and to notice how it started. And it's not always easy. The phones now allow us to film a lot of seizures, and it helps us tremendously to be able to understand what's going on. I think that considering that we showed that they have a lot of focal epilepsy, maybe we can shift a little bit the treatment. It seems like tegretol seems to be, carbamazepine seems to be very efficient in a lot of patients. And as I mentioned, I think that we should be cautious about some very strong reaction to benzodiazepine, which is not very common. So,
In
no?
genetic epilepsy.
Yeah,
yes.
but
Go on.
yeah, you will complete. Okay, that's it.
I don't have much to add to this answer. It's okay.
Very quickly, I think that the point basically is that today, in this disease, we are not treating the disease, we are treating the seizures and the epilepsy, and for this we only can rely on what we know from the treatment of seizures and epilepsy. If they are focal, we go more, as you showed, on carbamazepine. If they are generalized, we go more on therapies like levetiracetam or valproate or so on. And the point, I think, was, I do not need to conclude what was said by Aurore, is that all, I don't know how it is in many countries, but all medic aid people, unfortunately, whenever there is this, the seizure, it was this, the lady is not seeing, it was this, the seizure becomes generalized tonic-clonic. Generalized tonic-clonic are a very specific seizure type, and many of the focal seizures in a brain that has a low threshold to seize, you can initiate with a focal. And then it can diffuse. So you should, no, it's okay, I will not do anything. My ballet, I will not fall. I'm sorry, but you know what is falling from a seizure. So, but this is to say that when we do not see the onset of the seizure, we have this unfortunately bad habit to tag all generalized tonic-clonic. So please, as parents, and this is the best way you can help your doctors, just to try to take the photo of the, by phone, by camera, by whatever, or even describe, and just say, it began with, it initiated in this way. So this is very important, waiting for the specific therapy, hopefully, that can treat the etiology and the seizures at the same time.
I had a question. Sorry, I'll ask mine and then I'll pass the mic on. Can you comment on the use of adoption of a ketogenic diet and how that might impact seizures?
Actually, it's an interesting question, but I do not have data about that because in the series of patients, none of them had ketogenic treatment. Might be interesting, but I have no data to answer your question.
I would say that here we are treating with anti-seizure medications. Ketogenic diet has an anti-seizure effect. So I'm not at all shocked or surprised if in one patient that has a drug resistancy that we should, I'm not surprised, we should try ketogenic diet, except, Pascal, don't look at me, except if there is any interactions, but I don't believe so. I learned well my lesson about the metabolic pathway. So we can try it if it's useful. It is a very potent anti-seizure medication, but it is not, it seems, in your series or in literature.
At least for now.
Okay, you said that seizure is well controlled with anti-epileptic medication like valproate and carbamazepine, for example, and in most patients. And a few had severe refractory epilepsy. Would you please comment on the possible mechanism of pharmacoresistance?
Mechanisms of?
Pharmacoresistance, drug resistance.
No,
I don't have any.
No, don't worry. I will not take the micro every time. But I mean, pharmacoresistance is we can do 5 days of the workshop on that. There are different factors of pharmacoresistance that goes from predisposition genes for pharmacoresistant to predisposition to not to answer a given medication. I told you that many of our medications will work on the channels, for instance, or in the receptors. If you don't have a full action of this channel, this receptor, you might have a different answer to a medication. So today, the anti-seizure medications are mainly tested on models of seizures, animal models. We do electroshocks. There are a few tested on genetic models of epilepsies, and this is where we are initiating the development of orphan drugs in epilepsies that might be specifically for a given syndrome. But pharmacoresistance is something that is inflammatory process. I'm sorry, the third point is very important there. And in epilepsy, we say seizures beget seizures. So pharmacoresistance is also due to this vicious circle, but we do not have clear answers.
Thank you very much, Andreas Schulze, Toronto. Thank you, Rima, for explaining the difference between an epileptic encephalopathy versus a developmental encephalopathy, right? So the question is for Aurore, because you showed that there is a correlation between cognitive capabilities and epilepsy. That would imply, if this is a causative relationship, that if you control the seizures, you improve cognition in CTD. But there's also a good reason to believe that this is coincidence just because of the severity of the disease. So easily spoken, if someone has a severe, less residual activity of the creatine transporter, they have worse cognitive outcomes and epilepsy, while the milder ones have better cognition and no epilepsy. Can you comment on that?
So it's just, for now, it's just a description, and I really write it on the slide that it should be confirmed on a larger cohort. So I I don't think that we can, it's just descriptive. It's not a causal relationship that we showed. It's just a description that if we took the patients and it was comparable given their age and everything, the ones with epilepsy had lower IQ than the ones without epilepsy. I cannot say that it is because of epilepsy. It's just a fact that when we show that, we looked at that, we showed that. But I think that if we reproduce this on a larger cohort, it could be interesting because, I mean, either it's what you said, so it's not related and there is not a causative relationship between both, then on a larger cohort it will disappear. Whereas if it is consistent, I think it's interesting, and we know that one impacts the other. It's not always easy to at first say and conclude without a large cohort, in my opinion.
But you did not correlate with a genotype, for example, or with, let's say, studies of severity of the disease.
Yeah, so it's difficult. This is difficult because we have the genotypes, of course. For each patient, I have the genotype and the genetic characterization. The problem is that we have a lot of different mutation. So it is difficult to decide how you characterize, or maybe we could do, I don't know, the level of creatine uptake, because we also have fibroblasts, for example. So maybe it could be a good thing to look on the fibroblasts of the creatine uptake and then to correlate and to see if it's related or not.
Exactly.
Then I think that I could answer better to your question. So I will try to do that. But
no, I just want to emphasize one point that is very important. I was not implying that the disease we are talking about today is a DEE. It's up to you guys to tell me if it is a DEE or if it is a DE. Do you remember my DE?
I will show you one. I will show you one in the afternoon.
No.
That is clearly DE.
No. What I'm trying to say that what we know today is that when I look at the age of onset of the epilepsy in these cohorts, it is more appealing to say that we are in a DE and not a DEE. I'm sorry, are you following still my alphabet? Which, what I'm trying to say that usually when epilepsy has a major impact on development, we should have basically or a very, very early onset of epilepsy, like in early infantile developmental and epileptic encephalopathies. We should have usually a very abnormal EEG, which is not the case. We should have very frequent seizure. I'm sorry to say it like this. I know that one seizure every 6 months is important, but we should have like many seizures per day or per week. So we have some points here emphasizing that epilepsy per se might not be a cause of the cognitive whatever level. But we should be aware that in some situations and in some other diseases, whatever they are, at some moment, even in adult life, epilepsy can become explosive and can constitute an epileptic encephalopathy. So we should be aware about our definition. And the last point I wanted to emphasize, again, talking about this, please, I'm not in any way saying that seizures per se are not important to treat. Now we are more, because, I mean, can you imagine a child, even if he has all the other problems, if he's not seizing anymore, I mean, goodness, for the quality of life, it might be very important. But we are talking about the impact of the epilepsy, and I will end saying that when we have patients that where the etiology is the cause, we are much more tolerating some persisting seizures, and we are not chasing every single seizure, which might be also the case to understand.
I think it's time to stop. Thank you very much.